Hello everyone, Razia Mashkoor here. As you know, we had talked with Dr. Shams Iqbal from MGH Boston, where he is doing as Associate Chief of Division Interventional Radiology.
Hmm.
So we got so many questions from the public and friends, family. So we requested to Dr. Shams, please come back at BDC studio for one more time. So he is here, guys. Thank you so much for joining us,
Great to
Shams.
be here. Thank you.
So as we talk and you told us so many things 2 days ago, but here is few more questions, like how this virus or COVID-19 is different from other viruses.
Yeah, so first of all, thank you, Rajaji, to like have me back again. Um, as I was mentioning in the previous talk, the coronavirus is a group of viruses, and they all have same similarity in their visualization on electron microscope. When we look under the electron microscope, they look like a crown. So they are known as coronavirus. There are at least four or five well-known coronaviruses which we know, like SARS was the most famous, which came in 2000. Then MERS came in 2004. So this is of the same kind. Historically, the coronavirus lives in bat families mostly. So there a lot of them more are to be found because like we like research is an ongoing process. So this was a transmission, zoonotic transmission. This is what we call it, like zoonotic. Zoo is animal, and it comes from the animal. So it came from the bats to humans. So it's a new kind of coronavirus, and so they have the same pattern of infection. They all involve the respiratory system, and that's why like we have like talked so many times that the people with predisposing condition to respiratory functions, they are at a higher risk. So they all affect the respiratory system, and they this is a novel virus because first of all it's first time seen in the humans. Second, it has few characteristics which is perfect for epidemic slash pandemic because it takes a long time to show up, and by then the patient can infect other people, and it is low grade. So people don't die because there are certain diseases in which once you get infected you die, so you don't transmit to somebody else. So these are all the things which epidemiologists look for. So it's a new virus which the good part is like it causes low grade disease, but
Hmm.
it comes from the bats, and that's where we stand right now.
Wonderful. So regarding symptoms, how do one common people knows he got or he get the this deadly virus?
Yeah.
What
So
kind of
yeah, so this is what we call it like clinical symptoms. So
hmm,
as I was saying that like this is the first time this coronavirus is seen in humans, so we are learning a lot.
hmm,
There's a whole spectrum of sign symptom all the way from nothing. A lot of young patients we have seen like they are positive on the test, but they have no sign symptom. And initially we were testing like in a random way before the CDC came with the guidelines. And then the other extreme is like when people with show up with fulminant respiratory failure, means like they show up with incessant coughing, they have hypooxygenation, like low oxygen concentration in the body because the lungs cannot transmit. There's a severe pneumonia, and lung cannot transmit oxygen. They have low oxygen, and by the time we intubate them, they're dead. So this is the spectrum. For most of the people, the most common sign symptoms are like dry cough, high fever, and nose running, and upper respiratory kind of symptom, which we are very well aware of in the form of flu or cold. But it's just like it's much more severe in the form that if somebody has fever like 101 and above, then the risk is very high. And there's certain like CT findings, X-ray findings, but we are not relying on those much because the problem is like if we start running these X-rays and CTs on every patient, they are supportive for diagnosis, but then we are exposing so many extra people. And we don't feel like health industry as a whole, health world as a whole does not feel that there's significant enough of requirement to run these tests on them. So we just see the sign symptom, We look for these symptoms, and then if the patient has it, we run the test, and the test uh, is a PCR chain reaction.
Okay. So, if somebody call you, as we heard, that so many doctors and hospitals says stay at home
Mhm.
until you have these symptoms. It's too much similar with the pneumonia and cold.
Yes, yes.
How do you identify this is the virus thing?
So that's a good question. So yes, we cannot diagnose on the basis of sign and symptom.
Hmm.
Sign and symptom are a thing which the patient tells you or you feel with auscultation, examination. So because they all fall in the same parlance of a regular pneumonia versus like influenza pneumonia versus COVID-19 pneumonia and all those things. So that's why like uh, we rely a lot on test.
Hmm.
So anyone who comes with these sign symptom, we take it as a like a diagnosis of COVID-19 till proven otherwise, because right now that's the new virus in the system, and that's what we are trying to decrease the transmission. So we take everyone as like COVID positive, like anyone who comes with these sign symptom, we say like, okay, this is a COVID. We call them COVID rule out.
Okay.
So they are COVID rule out. We get
Hmm.
them in, we test them. If they're not too sick, we still send them back home. That's something which is like a very big weakness of the system, because we are afraid that these are the patients who will go and infect other people. So that's why quarantine is a huge element of this. So the way we are doing right now is like a patient calls in, hey doc, this is what we have, and we think that this is if the patient fits the criteria for coronavirus infection. We get them in, do the throat swab test, send them back, and ask them to quarantine. And if the patient is too sick, admit them overnight. And usually, like as I was saying, initially the test was done only by CDC, so it take like 2 to 3 days for the answer result to come back. Now we are doing in-house, and so we can get it on the same day. A lot of times, the clinical sign symptom are like so suggestive that we strongly believe that this patient is COVID-19 positive, and the test comes back negative. So we do them repeat testing. So
Hmm.
usually to call somebody negative, we are doing two negatives before we say we rule out COVID. Even on that scenario, there were like three patients in which we had to run the test 4 times, and the fourth time they came back as positive because the clinical symptom was so strong.
Yeah.
So as I said, like every a lot of things are in flux, in fluid state, and we are learning. Because I remember the third cases was like the pulmonologists were like very sure that no, this is COVID, and the test came back as negative, 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 and the fourth time it came back as positive.
Wow.
So so this is like something very difficult scenario to face.
Wonderful. Thank you. And one quick question is that this after the New York, whatever happened in New York, you know more than me. How Massachusetts is ready to fight with next 2 or 3 weeks? Because
Yeah. So
we heard that it is coming on the peak. It will going on the peak. So
yes,
what do you
yeah.
think?
In fact, I talked to you a couple of days ago. Today is like a Sunday evening, and tomorrow morning I'm back on service. And 7th is the first day of the surge, as we were mentioning about. And we have braced really strongly. To be very honest, I haven't seen it again. I've been practicing since almost 13 years here, and I've never seen such a preparation ever for anything, because it's a very unprecedented time. And like for example, I mentioned that like we have 100 ICU beds in the hospital, and we rearrange things in a way that now we have 400 plus ICU beds.
Wow.
That's like about almost half of the hospital capacity. This tells like the level we are preparing is on war footing. But still, we are still like banking on the shutting down of the system and social distancing, because even though we are like really well prepared, if the surge happens the way it happened in New York, I don't think any system is ready to take care of that.
Yeah.
So yes, we are ready, but we hope people, like anyone who's listening out there, they do understand that like this preparation is lesser of initiative than the social distancing. So please stay home, please keep social distancing.
So,
Thank you.
as in New York and as many other places around the globe, people social distancing they are not taking seriously. Yeah, they
uh,
are going. So tell them that's how social distancing is important in this today's life.
Yeah, so as I was saying, this disease is here to stay. It's not going to go away.
Yes.
Just like, for example, if you look around you, how many people do you know who have cancers? How many people do you know you have other infections? How many people you know you have they have big surgeries of their joints, knee replacement, all. So these things are of that kind. They will come and stay. The issue what we are facing is the surge. Like, the system will be overwhelmed with the number of cases at a single point of time. What we are trying to extend that number of cases coming over a period of time so that we can handle them. So which is what you must have heard, like flattening the curve. If you make a peak like this, in a certain point of time, there'll be too many patients, and we probably will have to face a similar predisposition, just like the Italian doctors had that, like they had one, like they used to have like several instances that they had one ventilator and five patients. So anyone who does not get a ventilator in that situation is most likely going to die. So we're pretty much giving them the death sentence. So but it's for the lack of resources, like, and even though we have much more resources, we are not ready for the huge surge. So what we are trying to do, like social distancing, what it does is like it makes the disease transmission to one person to the second person slowly. It does not excludes it. So that like somebody who's going to be sick tomorrow might get sick next week. So by then we can manage the others who have already gotten sick. Again, it's not absolute means, but
Yes.
history and science have shown that this works so good that a government, like a president who banks everything on Wall Street,
Yes.
he asks us to stay at home and not to do business. So this tells how significant this situation is and how seriously we are taking it as a system.
As a system. Yes, it is very important. Really, people need to know that. Dr. Shams, we have few questions to you about blood type A being more susceptible. Is it?
Yeah, so again, just like most of the other studies which we have seen, it is observational study that
Mm.
of all the patients which we have seen so far, you look at it and you see that a certain group, blood group is more common. Again, we don't know how, why, but again, we this much we know that the blood typing is based on antigen, and
Mm.
antigen are like they're like lock and key system on the cell surfaces, and the way the virus goes and attaches to them is like using those lock and keys. So probably there's something in there which works, but again, so we can look at it as like two ways. One is like it's a risk factor if you have like blood group A and that kind, or
Mm.
we can, if we can understand, decipher the orientation and the 3D model of that, we can use it as a treatment.
Mm.
But we are too early in that scenario. Yes. So the work is happening, research is happening on that, but that's one of the target site to manage the virus.
Venezuela. Thank you. And one more question is, if patients taking, as or inhabilator, what do you suggest? Are they on greater risk than the normal people or what?
Yeah, so ACE inhibitor is an antihypertensive, and like the population, the significant number of people have hypertension, and a lot of them have ACE inhibitors. It was shown that this virus has an interaction with the ACE and angiotensin converting enzymes, the receptor. So initially these are like, as we know that like there's so many treatments out there. One of the treatments was that ACE inhibitor could possibly work just like the blood group. So it's a epitope, it's a three-dimensional orientation, lock and key mechanism. So we are seeing that it's going and attaching there, so probably we can use this as a treatment. But it's again like it's way too early to use this as a treatment, and there are certain definite risk factors and side effects. So we are not using it on everyone because it's not a definite mechanism to treat so far.
Wonderful, wonderful. And want to say something to the community
Yes.
of Massachusetts? Please
Yes,
say.
so I there's one thing which has been bothering me, like WhatsApp University has been very
Yeah.
famous in these times, difficult times.
Yeah.
So everyone has some form of treatment. So please, 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 these like we as humans at in times of distress, we just hang on to anything which we feel like is sounds like good idea. But please don't try any of these treatments unless it's approved by CDC or FDA. And we are working hard on it. As last I checked, there were like 59 medications and combination of medication which were in the pile of FDA and CDC to for approval for this treatment, and they're all based on anecdotal science. So before we approve some treatment for this kind of disease, which is in employing like which is affecting the entire world, it's a huge effect. So if you're not sure and if you haven't shown studies, and we should not be trying on a mass basis. For example, like one of the words was like chloroquine was being used as treatment, and I just heard from like my friends in India that a couple of them there were at least couple of reports of physicians themselves overdosing and having they might have some
Yes.
underlying cardiac abnormality, and they died of cardiac failure,
Mm.
heart attack. There's a thing known as QTC prolongation, but I don't want to delve too deep in this. But these things are not without risks. So please don't jump into all these treatments unless it's approved by FDA. And usually these things take some time. So I don't know what else to say, but I'll just say, the best thing right now is to do like flattening the curve, social distancing, staying away from people. I'm the last one. I'm a very social person, but I'm the last one to say that. But looks like that's probably the call of the hour. Keep washing hands and help us fight this to the best of possible our capacities,
Yeah.
please.
Yes. And it's really important to go out. You have mask and
Yes,
you
so yeah,
can
the
remove.
other couple of points. One is like vaccine is on its way, but
Yeah.
usually the fastest we can make a vaccine is like 1 to 1.5 years. People who have been cured of this disease, like they have recovered, we are taking their bloods and like working on them and figuring out how to make vaccine for the patient for the healthy people. So it's on the way, but I believe it it will be like mid 2021 before we can have a vaccine.
Mm.
So and in addition to that, like if you are going away, you have to go out, please wear mask. And just see this afternoon, I believe CDC sent out a notice that everyone should wear mask, no matter immaterial of the position, location, or situation. Because
Situation.
so far we have come from the phase where like only when you see the patient we wear mask, then when we enter the hospital we wear mask, or to the point that we are at a stage where we CDC is saying that we are masked anywhere and everywhere. So
Everywhere. And
yeah,
the people.
probably that's the best way to fight it.
Absolutely. And the people who are going for grocery, especially, even you have mask, you have gloves, you do not touch each and everything. I'm just scared this. So tell me
Yeah,
what.
yeah. So this is a very like weird statement coming from a
Yeah.
physician, but looks like I have to say that please, please, please buy things which you only want. And once you figure out something, if you touch it with the intention of buying it. Don't
Yeah.
touch it for the intention of looking at
Just
things.
looking at this.
Please, and that's where like there's a huge transmission because of the
Yeah.
contact. And first of all, like wear gloves, please. Wear
Yeah.
gloves, and then if you have to touch something, just please buy it, because then you are the one who's handling that whatever you touched.
Yeah.
So I hope like
These are small
people that
things, but it can
it
spread
has huge effect.
at
Yes,
large.
I agree. I agree. These
Yeah.
have huge effect on a global scale. Please.
Yes. Just quick, because I already take so much time of you, but just quick, because as we are Indian,
Mhm.
tell me about Indian position a little bit, just quick one.
So again, the same thing. Like in India, we haven't heard the magnitude what we have seen in New York or the Western world. We haven't heard that in India. So
Hmm.
there could be two things. Either there's something which we are not, the scientific world is not aware of, which is happening, which is curbing the menace of the COVID-19, or they are behind the curve. And I wish they are not behind the curve. It's just that the probably the heat or something is helping them out, or their innate herd immunity, or yeah, as I mentioned in the previous episode, like they have like endemic malaria. It's supposedly a beneficial factor, or like the temperature and all these things. So I hope that's what working, because I don't think, looking at what New York is going through, I don't think any system in this world is capable of handling the sheer number of population which India has.
One questions or the video coming on Facebook or running around a lot. So many videos coming from there. This is if you get some the virus in you, it will stay from right here and your throat. Is it a myth or my?
So,
It's
so
true.
this is a mucosa harboring virus.
Hmm.
So mucosa, like what we see on the face is skin, but
Hmm.
starting from the lips and the inside of the nose all the way to the airway tract. So it's
Hmm.
a respiratory tract affinity virus, and it's a
Okay.
mucosa associated virus. So that's what we like, like touching your face. As long as I know it's a very innate habit of humans. I might have already touched few times myself while talking, while speaking, but this is where the virus sits, and that's where, like, when you touch with, for something like counting dollars or something, you touch your finger with a spit, and then you touch something else, and that's how the transmission works. So, and that's what we are afraid of. This is known as aerosol generated. So when
Mhm.
somebody coughs, when the wind comes from the mouth and the nose, it takes some virus sitting on the mucosa and comes out and makes tiny micro droplets, and then somebody else breathes in, it goes and sits in their mucosa. So yes, the way it's explained is not very scientific, but it's true that it's the face, nose, mouth, and the upper airway tract, which is where the virus sits and
Yes.
is ready to attack somebody else.
Hmm. So it's not a myth. It's really
Pretty
fact.
much, it's true. Yeah.
It's insert or going inside or our respiratory system through nose, noses. It's not a myth. It's a fact. So thank you so much for giving us time, second chance to talk to you, Dr. Shams Iqbal, and we will get back to you soon with more questions and more
I'm happy to help.
myth or fact. So thank you so
Yeah,
much
no
for
problem.
joining.
Thank you. Have a good one. Stay safe and keep washing hands.
You too. Thank you.